Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for doctors in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. This is the second in our series on safe prescribing, and today we're talking about telehealth and clinics with a very narrow or single scope of practice. Joining me today, again, I do have the lovely Kate Wills, who's a lawyer at Watankani. Thanks for joining us, Kate.
Thanks for having me.
And we have Dr. Tim Cookson, Dr. Lucy Gibbard, who Tim's are now retired from MPS, but still a very valued member of our podcast team. He's also a GP, and we've got Lucy, who's currently on the team and also a GP. Welcome.
Hi, Sam.
Thank you for your kind words, Sam.
I didn't use the word old, so I don't think I used that then, did I, Tim?
You've got to be very careful. There could be a lawsuit if you did.
So my name's Sam King, and my background is also general practice. You know, there are some terrible stats around medication error in general, which I did some research on. A systematic review showed, this is internationally, showed 3% of patients experience preventable medication-related harm worldwide. And 25% of those cases were classed as severe or potentially life-threatening. Nearly 50% of medication errors involve an inappropriate prescription. In the USA, medication errors are the third most common cause of death after heart disease and cancer. That's actually quite a scary thought, isn't it?
Seriously shocking. I don't know what study that was, Sam, but that seems mad.
Yeah, that was a study it was published back in 2009, so it's a little bit dated, but yeah, that was the statistics I found. In the UK, it is estimated that 38.4% of medication errors occur in primary care. That's a little bit sobering for us, isn't it? What about in New Zealand? There was a retrospective record review which was published in 2021 in primary care, and it demonstrated preventable or potentially preventable medication-related harms was 15.6 per 1,000 patient years. 21.2% of these harms were moderate or severe. 3 patients died in this review as a result. Increased age, number of consultations, and number of medications were associated with increased risk. Cardiovascular medications, antineoplastic, immunomodulatory agents, anticoagulants caused most of the harm. A local study in secondary care, which was published in 2017, there were 8 DHBs, as they were in those days, submitted data involving just over 2,500 chart reviews. Harms occurred at a rate of 34 per 100 admissions. I don't know, do you think that's high?
That seems high.
It does seem high, doesn't it? Those harmed were more likely to be older, female, and have increased length of stay. 29% originated in the community. Medicines that caused the most harm were opioids, anticoagulants, and antibiotics, as well as cardiovascular medications. Opioids and anticoagulants accounted for 40% of the harm and the most severe harm. And I think those statistics are pretty sobering, aren't they, when you think they're local? And now, as I'm sure everyone's aware who's listened to the podcast, there are increasing avenues for telehealth consultations now. And this, of course, greatly increases the risk of fragmented care, and prescription error is clearly likely if for example, if the diagnosis is wrong. I mean, I'm sure there are other sources of error, but let's start with the diagnosis. If we don't get the diagnosis right, clearly the medication and treatment we provide or prescribe won't be necessarily adequate. Lucy, what is it about telehealth that can contribute to diagnostic error?
Thanks, Sam. So look, I think telehealth is worth almost looking at in 2 separate systems. I think there's a telehealth where it's your normal GP who you normally see face to face, and you then book a telehealth follow-up. And I think that's probably a less risky form of telehealth as far as medical legal risk is concerned. Because you actually have access to the notes, you know the patient, you have the ability to bring them in because they're living in your local area. I think what we're probably more concerned about, the risks involved, are where that clinic is not the patient's usual provider. And I think more and more now, there's a lot of after-hours services which are telehealth. There's lots of single problem clinics that are telehealth. They often are quite remote from the patient. So actually, the counsellor very clearly tells us that if that patient needs an in-person assessment, we have to do it. But it's a little bit hard if they live on a different island from you, So I think that remoteness causes problems. I think also in a situation where it's not your usual provider doing the telehealth, the issue with, can that provider see your notes? There are some great systems now for seeing what medications patients have been seeing. So often that telehealth clinic may be able to see previous medications, but they may not have access to the classifications list or the recent consults or other really frank and important information about the patient's health, which means you end up relying on what the patient tells you. And I've had a case recently where the patient had a false belief about their own past history. The surgery they thought they had was actually a different surgery, and they confidently reported to the doctor that, oh, this is the surgery I had, and it wasn't. And it led to a series of adverse consequences for the patient. But, the patient had told the doctor that that's the operation she had had. So I think that's a classic problem with if you don't have access to notes, that actually you don't have that ability to check what the patient's told you, and the patient may not know their own history that well. So us relying on the patient telling us in those situations isn't always very safe. Also, obviously, in the telehealth, you don't have the opportunity to examine them, but even separate from just a formal examination, often just seeing the patient walk in and seeing how they're behaving, seeing how upset they are, seeing how much pain they're in, all those things can be a little bit lost, depending on, obviously, on the medium that's being used for telehealth, whether it's a phone call or a video or some other way of communication. But you tend to lose some of that non-verbal cues that you would normally get from a patient. We all know we speak differently on a phone call than we do when we're chatting to somebody. And I think, again, with the telehealth, there's a little bit more of a barrier. And it may mean that patients, you're not getting all the information that you'd have got if they'd been sitting next to you. You obviously haven't necessarily got the ability to know what that patient's health literacy is if you don't see them usually. And sometimes there's language barriers and other things which obviously occur in face-to-face consultations as well, but it may be a little bit more difficult when it's at the end of a phone or on a screen.
Yeah, well, with the language barriers, particularly if they've got an interpreter, the interpreter might be a family member with no clinical knowledge, as opposed to a formal interpreter.
So yeah, lots of potential for error in that situation.
Interesting, you were talking about GPs where patients are having telehealth with their own normal provider, and research has shown or indicated that it's just as safe if you are seeing your regular GP by telehealth, that it can be just as safe as an in-person consultation.
Yeah, and you can see that.
And you can see why, can't you?
And we do often do that as a GP. If you've got a patient who lives a long way away, you see them for their initial assessment, and then you say, look, don't come back for the follow-up. Let's just do that telehealth because, and it's a completely different scenario,
completely
isn't
different,
it?
isn't it?
In fact, long before telehealth became a word, we've been doing telehealth because we've been ringing our patients 30, 40 years ago and having that conversation on the phone. Oh, great, the antibiotics are working. Excellent. I don't need to see you again. That sort of stuff. So
he just wasn't called.
It's been part of practice.
Yeah, that's true.
It was called a phone call on a landline.
A landline? Ooh.
What's that?
So, Tim, are there any other factors where diagnosis or making a correct diagnosis might be difficult with regards to telehealth?
Yeah, well, Lucy's already referred to the fact that you can't do an examination, or at best you can see someone on a video call. And that creates all kinds of pressures because it may be a condition where really an examination could be very useful. I mean, we know in general terms that examinations don't add a huge amount to diagnostic ability, but there are some conditions where it might definitely. Abdominal pain, for example, headache. Those are things where, without examining your patient, you are quite likely to miss something. And so, as Lucy said, if it's a GP based in the North Island who's talking to a patient in Gore, then they're not going to be able to just pop in to see that GP telehealth provider. Often the telehealth providers have no facility to see people anyway. So they're going to have to direct them to another provider to get that examination. And there are going to be barriers there. Patients may say, well, you may say I need a consult, but I'm not going to go, but I still need, whatever it is I need. And so the telehealth providers in that awful position of saying, well, if I don't prescribe, for example, the patient may end up worse off, but actually they need to be seen to get it's a kind of a no-win situation. So I think that's a real pressure on the telehealth providers. It's a risk for patient, but it's also a vulnerability for the telehealth provider. There are all kinds of factors that affect patients. It's cost, it's transportability, and availability. If you've got a 3 to 6 week waiting list to see your GP, your condition may well have changed significantly in that time. And it's interesting, telehealth, all the same risks that are seen in after-hours clinics, which we know generate a higher proportion of complaints than seeing a regular GP, because you've never met the person before, you've got no idea what they're like, you don't know whether they lie about what surgery they've had previously or not, and all of those create potential gaps, in which you can fall into huge diagnostic holes.
Mm-hmm. I assume both of you, Tim and Lucy, have done some telehealth.
Yep.
Or you still do some telehealth. And I do find, for me anyway, I guess because in the place that I'm working, often I don't know the patients particularly well. I have their clinical notes in front of me, but they're often not my patient. It's actually quite fraught. I guess it doesn't help when you work for MPS. You tend to be a little bit perhaps over the top. But I do find that, for me, it is about, do I need to see them? What could this possibly be? Thinking very clearly about a differential diagnosis. And do I really need to bring them in?
I often think you're seeing things that people say, oh, it's just a cold, or it's just they're acute.
Yes.
And you forget that actually how many times in your life have you seen a kid that you think, oh, that kid looks all right, and then you do their obs, and they've got a pulse of 150 and a temperature of whatever, and actually you thought, oh, they didn't look that bad, but when I did their obs, actually they were. And just not having the obs is a big risk, I think. I think the more telehealth providers can, I'm sure there's going to end up with systems where you have a link through your phone where they can do your obs through your phone or something. There must be one day, but I think it's the real basics of temperature, pulse, blood pressures that you kind of often get surprised at when you actually do them, that you think, well, I wouldn't have even done them, but they were there.
Kate, can I just bring you in here? How would the HDC view mitigating factors such as, we were busy, there were pressure on appointments, so we had this quick consult, and the patient refused to come in, they were living, a 2-hour drive away. Do you think the HDC would take that into account if something went wrong with regards to a telehealth appointment?
I'm sure all clinicians will know about the HDC's code and the 10 consumer rights and provider duties that entails. What clinicians might not be so aware about is that there is actually provision in the code, clause 3, which sits under those 10 rights, that suggests that the circumstances or context of care can be argued as relevant to whether it is right or fair to find a code breach. I'll read the clause itself. It states, a provider is not in breach of this code if the provider has taken reasonable actions in the circumstances to give effect to the rights and comply with the duties in this code. The onus is on the provider to prove that it took those reasonable actions. And for the purpose of this clause, the circumstances means all the relevant circumstances, including the consumer's clinical circumstances and the provider's resource constraints. So we all know that errors made by clinicians can often be the result of or influenced by systemic pressures outside of their control, like time-limited consultations, massive patient demand, and insufficient support. So we do often rely or seek to rely on this clause 3 and argue that the clinician did the best with what they had, and the HDC must consider the practice context and pressures. I don't know if you guys would agree with me, but my experience is this does not always succeed with the HDC when we seek to rely on this clause. Our experience is most often clinicians will be held accountable for the care they provide, despite contextual pressures. For the HDC, it seems the appropriateness of the clinical care will be the focus. And if there was limited time to gather the information needed to ensure that a certain prescription was safe and appropriate, I would expect the HDC would not regard time constraints as an excuse for not seeking that information out. If a patient refused to come in and it was considered clinically necessary or important that an assessment in person took place before providing certain treatment, I would expect the HDC could be critical about treatment being provided based on a virtual consultation only. There, of course, may and will be exceptions. You touched on this briefly before, Tim, such as where required treatment might be time critical. And in such a case, liability could possibly be avoided if there was evidence of an appropriate risk assessment by the doctor, saying, I need to see you, I need to do an assessment in person, but you're saying no really resolutely and you quite swiftly need this medication. Weigh the risks, talk to the patient about the fact that you are weighing those risks and what the risks are, and document it. You might be, that might be an argument to put to the HDC that might be listened to, but I think generally they'll be looking at what you did and what is safest for the patient. And if that it means saying no, you have to come in, the HDC will probably expect that.
You're very unlikely to be, unless it's an acute situation with somebody with something that's absolutely an emergency, I think you're very unlikely to be criticised if you said, I need to see you, I'm not going to prescribe unless I see you. No one's going to say you should have prescribed unless it is an emergency situation, or that there's no other way the patient can get that medication and it's, life-threatening. So I think the doctor is safer saying, I can't do this. But, I do think that whole thing of what you document is so important. If you've told the patient, these are the risks if I prescribe without that, But even in that situation, I think the doctor will be safer not to prescribe.
So the patient who presents to the telehealth provider with a chest infection, the telehealth provider says, you need to be seen. The patient says, I absolutely refuse. And then 4 days later, they're admitted to hospital, in severe respiratory distress.
I told you needed to be seen.
But complains against the telehealth provider for not prescribing the antibiotics, which would have prevented things or could have prevented things from progressing.
Yeah, and in that situation, you've got to say, what is the less risk of harm?
Yes.
And actually, the less risk of harm is providing the antibiotics with a very good safety net. But you're still going to get criticised. I think that's the problem.
Maybe you do a short, you make sure that what you do prescribe is short and,
except for
targeted.
Antibiotics, you can't really do that. But maybe what you do is you say, okay, if you're absolutely refusing to come in, but you will go to your pharmacy and get some antibiotics, then we need to have another consultation this afternoon or tomorrow morning, and we're going to do it, we're going to do very close follow-up rather than just let it go. It's a no-win, isn't it?
It's a big dilemma for any prescriber where the patient needs the medication but they refuse to come in or refuse to have their monitoring. It is that age-old thing of balance of harms, isn't it? And that's not an easy balance to weigh often for the clinician. And I would suggest in that situation that maybe you discuss it with colleagues. What do you think I should do in this situation? Do you think I should prescribe? Is it safer to do that, or whether I should not do that? And possibly call the hospital, speak to whichever specialty you need to. This is the situation. Do you think there is a risk? And what do you think I should do? So if you by consulting widely about it, I think you protect your medico-legal risk.
And documenting that you've consulted
Yes, of course.
widely.
Everything. And documenting the patient's aware of the risk.
And particularly where they've refused to do something that you regard as being the right course of action, documenting how hard you've tried to convince the patient that was the right thing to do. Because often patients turn around and say, oh, but the doctor didn't make it clear that I really needed to be seen. And so having documentary evidence that you've really done your level best is certainly a help.
Yes. So if we move on to the actual prescribing, not just diagnosis, although we have been obviously touching on this, there has been a recent big shift as a result of the government policy in terms of the availability of telehealth, basically anywhere, anytime. That's I think how they've gone. And it means that increasingly the patient is unlikely to be consulted by a GP that they're enrolled with, and there are no clinical notes. And also there are many clinics now with a very narrow scope of practice, such as cannabis clinics or men's clinics. I expect Wegovy clinics to spring up everywhere, or ADHD clinics as well. And I think that it is not uncommon for patients to have phone consultations, for whatever reason that is, whether it be geography or convenience. Now, the Medical Council statement provides standards for doctors, of course. And Kate, what are the relevant guidelines relating to this issue?
The Medical Council has a statement that specifically addresses its expectations in respect of telehealth. That's on the council website, and I implore clinicians to look at it because it's the standard to which you will be held by the council, the HDC, and the Health Practitioners Disciplinary Tribunal if you ever find yourself there. As an overarching principle in this telehealth statement, it's noted the standard of care you provide to a patient via a telehealth consultation should be the same as the standard of care provided in an in-person consultation within the limitations imposed by the telehealth modality. It is important to recognise limitations of telehealth and consider whether an in-person examination or assessment are required. The statement is explicit. The practitioner is responsible for obtaining sufficient, reliable information for any diagnosis made, and this might require objective confirmation of the information being reported by a patient. For example, maybe requesting copies of referrals or permission to request information from other providers. The Council expects patients are, where necessary, advised about follow-up care, taking into account the local services available. And this is where it gets quite onerous and where geography could be relevant. If the Council expects that if you don't know what's available, you should take reasonable steps to find out. So you might need to, if you're based in Auckland and the patient's in Gore, get on Google and find clinics in Gore that they may need to be sent to for a physical assessment. If you practice telehealth, you should have a plan for arranging physical examinations for patients who require them, and a means for relevant information obtained from those physical examinations to be provided back to you or to the patient's regular doctor. It will be the responsibility of the telehealth provider to follow up the results of any investigations they request and the outcomes of referrals they make. And in respect of prescriptions in a telehealth context, the requirements of the other council statements, such as good prescribing practice, will apply. That statement on prescribing directs that you should only prescribe a medication or treatment, including repeat prescriptions, when you have adequate knowledge of the patient's condition. You must be satisfied that the medication or treatment is in the patient's best interests and there are appropriate arrangements for follow-up. So these are onerous requirements that need to be met in a virtual sort of mode.
When we think about the whole thing of adequate knowledge, if you've got clinicians who are seeing patients only by telehealth and you don't have any clinical notes, Lucy, what do you think it means to have adequate knowledge of your patients? How can you acquire adequate knowledge of your patients?
Yeah, I think there's a few ways you can acquire adequate knowledge. So it's not like it's not possible, it's just onerous. And the question is whether you should be doing it, and are you doing it? So I think there are definitely systems throughout the country, One Health in the South Highland, where you can actually break the glass and get into a system where you can get access to results and prescriptions and some hospital notes. So it may be that you have an electronic system where you can access at least parts of the patient notes, and if that is available, then you will be expected to be doing it. The other thing, particularly with the single-use clinics, if they are seeing a patient who has self-referred to a clinic, it would be a reasonable expectation that you actually ask the GP to send you a referral letter, or at least a summary of their past history, so that you can get something from the patient's current provider. It's obviously not the same for if it was an emergency telehealth clinic, which maybe after hours the GP's not there. But if you were seeing somebody in an ADHD clinic or a cannabis clinic, that you may be expected to pick up the phone or email another doctor and say, please, can you give me the background I need to do to safely prescribe for this patient? I think there are some clinics that do that more than others, but I think definitely the onus is on the individual clinician, not the employer or the clinic or anybody else. It's the individual clinician who's doing the prescribing has that duty to find out that background history. And I think, as per the case I talked about recently, was the risk if you only rely on the patient telling you what they know of their history. For a start, they may not know their history very well. They may have other biases or reasons for not telling you something about their history. So I think you do need to get corroboration, and you do need to seek that information elsewhere.
Kate, do you think that ought to be the accepted starting point unless you've got good reason not to? Contact the GP, find out a good history?
I think it would be expected by the council. There's a little footnote in their statement related to what they perceive comprises adequate knowledge of the patient's condition. The council says, at a minimum, this should include the history of their condition, previous and current other medical conditions, previous adverse reactions or allergies to medicines, and concurrent or recent use of medicines. So the council expects you to find that information, and I would think we would want to see described in the notes the efforts made, attempts made to get that information from the patient directly, potentially from elsewhere.
What if the patient says, I don't know how often this would happen, but what if the patient says, no, I don't want you to contact my GP? Tim, what do you think?
Well, you're obliged to follow that instruction, but that then creates limits on how you can help the patient, and it may force you into a situation where you say, look, I'm terribly sorry, but unless I get that information, I can't actually safely help you. So we're a bit of an impasse here. What do you suggest we do?
Yeah, I wonder whether if someone's come to you specifically because they want Wegovy, for example, and they're paying you presumably a reasonable amount of money to obtain that medication, and you're putting roadblocks in front of them, I imagine that it's not that easy then to just say, no, I'm sorry, I can't do this today. We need to do this, and if you can't, if you're not going to give me the information or I need time to find it, I imagine that the patients can be a little unhappy about that.
Well, that would put particular pressure on that provider, because if that's all they do, the last thing they want is for information to go around the community that, well, there's no use going there, you pay $150 and you don't get your prescription. So, it's the last kind of publicity. So those doctors will feel a real pressure to actually prescribe, even in situations which may not be consistent with the medical council statement on prescribing.
And I think the thing with Wegovy particularly is that knowing the patient's weight, and obviously you can't actually weigh your patient in a telehealth thing, but the patient can say, this is my weight. But then how do you corroborate that's what their weight? So how do you know it's within the MedSafe indications for appropriate use if you don't know their weight?
And the patient is, in fact, anorexic.
Yeah.
Yeah, I mean, it's easy to lie I lie all the time about those sorts of statistics, because I don't want anyone to know the actual truth. So, I mean, it is easy, isn't it, to not be entirely honest with a clinician over the phone.
What do you think the HDC would do there if you prescribed a medication which had an indication relating to a patient's weight, and the patient told you the wrong weight? Are you entitled to trust your patients telling you the correct weight? Or would you be expected to corroborate that yourself? Do you think if it makes a significant difference to whether or not that medication is actually indicated?
Yeah, not so much in regards to prescribing, but I think about other HDC cases, where the patient has this unexplained weight loss, or they're saying to the doctor, I've lost 6 kilos over the last month and I don't know why. And doctors have been criticised by the HDC for not monitoring that weight, but just relying on the patient saying, I've lost another 2 kilos or I haven't lost any more, doctor. So if that's an in-person consultation and they receive criticism from the HDC around that, I suspect there would be criticism. If you're prescribing for a weight loss drug, for example, but you haven't physically assessed your patient. Kate, I don't know.
I'm nodding. I think that's right. It all goes to like the clinical appropriateness, and if weight is an important factor, particularly if not having an accurate understanding of weight heightens risk or anything like that, or makes the prescribing completely inappropriate, I think the HDC would be critical.
Often with some of these clinics, it seems that it doesn't necessarily happen where the GPs are informed that the patient has been seen there, any medication that has been prescribed. Is there medico-legal risk there for the prescribing doctor in that situation?
I think they'd be protected to an extent where the statement acknowledges the primacy of the patient's right to choose. The statement does say if the patient consents, you can share information with the doctor. The patient has privacy rights in respect of their health information. So I think certainly I would encourage the clinician to have a good conversation with the patient about the importance of sharing this information with the doctor. It gives them with their regular GP if they have one, it gives them a full picture of what we've done here in this limited consult that can be understood in the broader context of your health, which is really important. Have that discussion, write down that you've had that discussion, say that your preference would be to bring the GP in by sending them a note of what's happened, and then if the patient retains their refusal, then you've made an effort to at least cover your bottom to an extent.
Because the council certainly, I think, has an expectation, and in the statement it says if you're not the patient's regular doctor, you must ensure that information about any care you provide and prescriptions you issue is given to that doctor. And then there's the proviso, unless the patient does not agree. So it's clear the starting point is the expectation is the information will go. It's an exceptional circumstance which says the patient that the information won't be transmitted, and it's only on patient refusal. So you'd expect those clinics to have a policy, and I think like most after-hours clinics where patients get given a little note to say, your notes will be sent to your GP, unless you specifically request for that not to happen.
So we've talked a bit about the medical council statements that we're measured by, and we've talked about the good prescribing practice, we've talked about telehealth statement, but there's also good medical practice, and which is quite a long statement, which we all need to get a hold of. But so Tim, I think you've had a look at that. Can you tell me if there are any differences or concerns that you might have around that?
Well, there's just a little bit of slightly different emphasis, if you like, in the statements. So the statement on prescribing says that counsel expects you to have a consultation with the patient. If a consultation is not possible because of exceptional circumstances, then there are a number of things you can do. Whereas if you look at good medical practice, it says before prescribing any medicine for the first time to a patient, an in-person consultation is recommended practice, which is slightly different from expects. And then it says, if in the circumstances you are unable to see the patient in person, consider a telehealth consultation. So there's an interesting difference in emphasis there. And, that may be something for future discussions with the medical council, because it is a bit confusing, which is the real expectation. What is the standard that council will hold you to of those two?
I think too, with the government's this government's approach to increasing the availability of telehealth with non-enrolled providers, I think that those statements will be tested, won't they? So it's probably important. It'd be important for medical council to clarify that at some stage. Thanks for putting that out. Lucy, do you think there's any reasonable cause for a telehealth provider to provide a 6-month, 12-month prescription?
Well, there's exception to every rule, Sam. So I think the rule should be that if it's not you're the regular provider, whether it's telehealth or any other kind of thing, I think that the script length should be limited. However, there probably are exceptions where there will be occasional situations, maybe it's a script for vitamin D or something like that, where you think this is totally safe and I'm not at all worried and I'm happy to give a 12-month script for vitamin D. So I think you've got to take each individual patient and each individual script on its own merits. But I think as a general rule, when you're not the normal medical provider for a patient, you should have caution about prescribing very long scripts.
And again, a telehealth clinic could provide some protection for the individual clinicians in terms of patient expectations by having a policy that says, because we're a telehealth clinic and we don't know you personally, we have a limit of 3-month prescriptions for all prescriptions, except oral contraceptive maybe. So.
Anecdotally, I don't have any specific research numbers on this, but we receive a number of complaints because patients don't get the prescription they want, be it opioids or whatever it happens to be. And so patients complain, which, as we all know, is uncomfortable for all doctors to receive any kind of complaint. On the other hand, patients are less likely to complain if you just give them what they want. However, if something goes wrong and they have an adverse outcome, then they will go back and question the doctor around their prescribing. So, Kate, actually Tim and Lucy, do you have any advice for prescribers in these situations and how they need to manage the risk of complaint?
Well, I think, if you look at the overall situation, I think you're almost always going to be less vulnerable if you decline to prescribe something that you really don't believe there's an indication for. Clearly you have to give, good documentation because that the patient may well complain in that situation. But just casting my mind back, I can't think of any doctor who really got into significant trouble with the HDC with good grounds, refusing a prescription, whereas we've certainly had lots of cases where doctors run into trouble for prescribing things that were clearly not appropriate.
Yes, I think that it's easy when we receive a complaint to think, because the patient's unhappy, I must be vulnerable. But I think it's really good to know that actually if you do the right thing and a patient complains, you're not going to be criticised if it goes to the HDC or other places.
Of course, you could still be criticised for your communication with the patient, and with you explained it carefully enough. But in terms of significant consequences, refusal is much less likely to create vulnerability.
But I do think communication and documentation are the other two pillars of trying to avoid complaints. It's really important that if you're refusing a script, you explain to the patient why you're unhappy to give it, if there were circumstances under which you would give it, and what criteria would have to be fulfilled for that to be considered safe. So I think you'd have to communicate very clearly why you were refusing, and then you'd have to document that you have communicated clearly, and that and if it's something that you feel that some of your colleagues would prescribe, you can say, look, I can discuss this with my peers. You can often say, look, I don't feel this is my area of expertise, and this is a medication that I haven't got a lot of experience with, therefore, I'm not the right person. That doesn't mean to say nobody is,
No, that's good.
And sometimes in terms of, if you think about preventing complaints, in a situation where your patients come in clearly with a very different expectation to the outcome that you're presenting them with, you might think in that situation, would it be a good idea for me not to charge this patient in this circumstance? Because then often it's the charging on top of not getting what they wanted that creates the.
That's very
and
true.
I can think of cases where I've seen patients and they had expectations that I clearly wasn't going to be able to meet, and I listened to them and had the consultation and said, "Look, I'm terribly sorry, I can't fulfill your expectations. Look, I'm not going to charge you for today's consultation. Nice to meet you, etc." Maybe
that's a really good tip, I think, Tim. If you can avoid charging them when you know they're not going to be happy, then you might avoid a complaint.
Yes, because the time it takes to respond to a complaint is significantly outweighs the amount of money that you get for that consultation.
Yeah. Oh, well, thank you for your discussion, everybody, and thank you to our listeners for listening to this podcast, and we do hope it's been helpful. And we do look forward to catching up with you in our next podcast, which is part 3 of our prescribing series. And this will be on standing orders and prescribing on the recommendation or the request of our colleagues. If you like the Medical Protection Podcast, please subscribe and leave a review. If you would like a podcast on a specific topic, please email nzpodcasts@medicalprotection.org.